Hello everybody, my name is Marcin Malka. I represent Podos Wound Care Clinic and I'm also Medical Affairs Director of Podos Clinic and General Surgeon and Angiologist. And today I want to share with you my team experience in treating patients with chronic wounds and with infection. This webinar is organized with cooperation of Smith & Nephew Company. We cooperate with Smith & Nephew from almost 10 years. And we organize a lot of workshops, a lot of educational meetings, events, and also webinars. So let's start. A very important question at the beginning. Do you hear me and do you see me well? If yes, please yes on our chat. There are some problems with, yes, thank you, Eden. So let's start. A very complicated problem. Why? Because more than half of our patients has a problem with infection, and it's from times to times the reason for lost the limb and lost the life. So it's very important to discuss about this. At the beginning, very important slide, disclaimer, the most important part, that Smith & Nephew does not provide medical advice and is not responsible for the content of information. It's only my own opinion, my own experience, and I think it's normal situation. And do you agree with me that it's not a guidelines, it's mine own experience? The two cases at the beginning, one was failed. Unfortunately, we lost the limb, and the second was succeed. Why there was a difference? Very similar patients, very similar problem. Why from times to times we lost the limb? A 67-year-old man with left foot phlegmon, with diabetic mellitus type 2 from few months, because it was the first sign of this diabetes was the diabetic foot syndrome. And there was also he was also a smoker, and he suffered from atrial fibrillation. These are the pictures from the first visit. It's serious, but there is not so serious. We saved the limb, very more complicated. So it was not normal situation. Then we lost this kind of limb. At the first visit, there was very high heart rate, so there is infection, a good ankle brachial index, and a total foot neuropathy. So it was the diabetic foot syndrome, neuropathic diabetic foot syndrome, and the infection connected with this. What we start at the first visit? Regional anesthesia of the left foot, because there was a pain. There was a neuropathy, but there was a pain. Cleansing, rinsing, and debridement, a very important part of our fight with infection. Very important weapons. I will tell you about these processes in this presentation. Microbiological biopsy. It's not only the swab. It is a deep tissue biopsy, microbiological biopsy. It's very important to start with correct antibiotic therapy, and it is the reason why microbiological biopsy is so important. And using of antiseptics. So after debridement and cleansing, we use antiseptics in case of infected wound. Antimicrobial dressings. We have a lot of dressings in the market, but there are there's a lot of type in net, in super absorbent, in foam. So there's a lot of kinds of silver and a lot of kinds of matrix for this silver. So so it's important to choose correct product. There was also hypertonia, so we need a intravenous liquid for these patients. And because there was a hypertonia, we decided to refer this patient to the hospital because it was too risky to do it in outpatient clinic. We are only outpatient clinic. And the results of our microbiological results was very complicated. And there are MDRO microbias and also very dangerous microbias in wound like Enterococcus fecalis and Proteus mirabilis. So, and also Bacteroides. So it was complicated, and we decide to start with empiric antibiotic therapy, and also we change it to the another after taking the antibiogram. And this is the 1 month of our fight with infection and our treatment plan for the 1 month. Unfortunately, there was no succeed. There was an amputation, and the decision about the amputation was after 3 weeks. It was 13 July. We start 21 June. So why we decide to amputate? Because normally in outpatient wound care clinic we save the limb before amputation. It was something special for us. There was a lot of activities. Look here, antibiotic therapy per os. Maybe it was one of our bad decision that we choose the per os antibiotic, nor intravenous. And there was not so good glycemia, so there was a lot of diabetologist consultation. It was 5, 6, 7 diabetologist consultation during this month to correct this glycemia. There was a lot of outpatient visits observed. Every 2-3 days there was visits, and we start very fast with negative pressure wound therapy. It's here, and total contact cast, because there was broken the ankle joint, so it was necessary for the stabilization of the feet. But unfortunately, we was failed. Look at the pictures. There was a problem with dorsal part of this feet because there was a phlegmon, and after a few days there was open joint. Maybe it's not good quality of these pictures, but on the last picture you can observe the open ankle joint. So it was the decision that it's impossible to give this patient mobility. Maybe it's possible to save this limb, but without mobility, so it's nothing for us. We need a mobility, and so we decide to prepare the patient for amputation. But the question is why? Where were the mistakes? Why we filed it? Why we have no good ideas? We have a lot of ideas, a lot of equipments. So I spent a few hours thinking about this problem, because it was it was very important to me to try avoid the amputation. A very long story of diabetes before it was diagnosed. Because it was diagnosed 1 month before starting the treating in PODOS, and it was diagnosed because there was diabetic foot syndrome, but the patient has the symptoms of diabetes from the lot of years before, and he was not interested to react for it. And there was also difficult to control hyperglycemia. After 10 days of treatment, there was hyperglycemia less than 300 milligram of percentage. So we have a good experience with this kind of patient, but in this case, it was very difficult. And the patient used his leg, despite he had a very clear instruction and education in using of wheelchair, and we tried during the first visit how to use the wheelchair and completely offload this left leg. So there was no full compliance between us. And the problem for which I am responsible is the antibiotics. We decide to try give this patient per os antibiotics. After discharge from the hospital, after 3 days, he decided to give him per os antibiotics, and we continue it. And the ankle joint was opened. It's a very difficult situation because there is impossible to close so big joint in the case of infection. So it was the decision that amputation is necessary. And maybe there was also my mistake that we didn't do an ultrasound or MRI exercise at the first visit, because there was probably there was a liquid in the ankle joint, and probably there was a infection, and we don't saw it. So maybe it was one of the reasons. And the second patient, completely different finish of the treatment, because we are succeed. But at the beginning, very similar situation. Also, 64 years old man with right foot phlegmon, with Charcot osteoarthropathy, with a very bad sign of the MRI. This is the abscessus here, and there was also heel amputation before starting treating in our clinic. So it's not good for the mobility patient in the future. And there was also PAD, peripheral artery disease, after 2 times of PTA. So it's maybe worst case than the last one. And there was also obesity, hypertension, and patients have a possibility to save this limb, and he was not satisfied with healing process in Germany, and he came to our clinic, and he started a healing process in our clinic. What we do, the same, cleansing, rinsing, debridement, very important part of our fighting with infection. Microbiological biopsy, using of antiseptics, antimicrobial and superabsorbent dressing. And patient also was referred to the hospital because he was subseptic. So we decided it's too high risk to do it in outpatient clinic. And now we finished 9 months of healing process. We start at December. Now we have a September. There was 33 outpatient visits every 3 days. There was 9 diabetologist consultation, and now this glycemia is good controlled. We also have a blood transfusion, a 5 times MRI, 33 application of negative pressure wound therapy. It was Renasis, and also 24 application of total contact cast. There was also 2 application of Cerament with gentamicin. It's substitute, bony substitute with antibiotic. It was necessary because there was osteomyelitis, and there is very hard to resolve this problem without osteotomy, without substitutes, bone substitutes with antibiotics, and without oral antibiotics. So we do all this procedure, and we have a lot of successes in the case of osteomyelitis. And also skin graft, because there was a very big area of the wound on the plantar area, and 10 years ago it was forbidden because there was no proper offloading, proper shoes. Now we have a lot of experience in good quality insoles, good quality shoes, and it's possible to save the skin graft, the skin after skin graft for the years. So it was not a problem. And this is the day during skin graft outpatient procedure in our clinic, and 7 days after. And this is the last picture, maybe 3-4 days before. So the wound is closed. There is only a small fistula to the ankle bone, and we plan to close it with the third time of bone substitute application. Now we clean it, rinse it, and we use the Acticoat Flex. But for a few days, we have a plan to close it with bone substitute. So very similar patients, but completely another finish of this treatment. And why we did succeed in this case? We did the MRI to look for gaps. So there was a lot of 5 times MRI, and the first one was a few days after the first visit. So you have to choose. Maybe USG is good, but USG is problematic in case of infected wounds. So MRI is also better for the soft tissue and for the osteomyelitis. Difficult to control at hyperglycemia, so we applied Eversense system for monitoring of glycemia, and after a few days we know everything about this patient behavior and level of glycemia. We implemented antibiotics intravenously, so it's important. If in case of spreading infection, especially in diabetes patients, we have to choose intravenous antibiotic. It's of course problematic in outpatient clinic. We do it, but the patients are from all Poland, and sometimes there is 200-300 kilometers to our clinic, and it's impossible to do it 3 times daily. But we try to do it, and almost all our patients with spreading infection have the possibility to use intravenously antibiotic therapy. And we also introduce the topical antibiotic in sponge. It's necessary and very helpful in the case of osteomyelitis. The patient was good in compliance about offloading, so he uses total contact cast and wheelchair, and it's absolutely offloaded, so it's very necessary in the case of Charcot or osteoarthropathy. And very important at the finish of my presentation of this case, there was no patient restriction on the use of modern dressing and methods. It's not so easy to organize this kind of healing process in an outpatient clinic, but of course it is possible in Poland, but it's not fully covered by government. So it depends from the patients, and in this case we have any restriction to use every procedure, every antimicrobial dressings, so it was easier for us to use this product, and I think it's one of the reasons for succeed. Okay, so it was the start. Normally we finish with the cases. In this case, we start with the cases. If you have any question, ask me during the presentation, but at the finish of this presentation, I prepare 5 minutes for the especially dedicated for the questions. So how to organize the healing process for the patient with infection? We have a very long first visits for every patient. Also the patients with infection, and why 2 hours? Because we need to analyze all the problems. Sometimes we have a sign of infection, but the most problematic is, for example, malnutrition or another offloading, hyperglycemia, doesn't control it. So a lot of problems. So first visit, very important part of good quality healing in every good clinic in Europe. So I think it's necessary to prepare the very long first visit. Sometimes we need 3 hours. Today at the morning I had only 2 first visits. Every was 2.5 hours, and 2 small nail surgery, nail plastic surgery for 1.5 hours. So only 4 patients daily. Not so many, but I need a lot of time for the first visit. So we need a team for realize this procedure. We need nurses, we need a diabetology surgeon, we need a physiotherapist, we need a podologist. So a lot of doctors, a lot of nurses, a lot of medical staff for organizing this healing process. For example, in our clinic, we have around 300 patients during the healing processes, and we have almost 50 employees. So a lot of people, very very big team to organize high quality care about this patient. Removal of all causes for chronic wounds. So we have to start at the beginning. Our fight with hyperglycemia, with malnutrition. So we need a dietitian consultation. We need to introduce some additional nutrition foods. We need a lot of activities, so we cooperate with physiotherapists. We have 4 physiotherapists at this moment, and in the same time proper local treatment, I mean antimicrobial activity. Okay, and all this system is closed in time strategy, but today we have a plan to talk about only a quarter of this plan about infection and inflammation. Very important to recognize this infection. We had a problem from time to time. We are not sure it's infection or not. It's biofilm probably. So it's not so complicated to analyze the quality of microbes in the wound, but there is not the answer for the question there is infection or not. So we have to use our experience for this answer. Of course, there is some simple sign like reddening, pain, increasing warming around the wound, edema, skin edema, pus exudate, other. But there is also not so easy to observe signs of infection. Look at this patient. There is some changes in the skin color. Yes, there are some cannulas. There are some problem with some caves in the wound. There was no caves, and after a few visits, there is a cave. So there is no oedema, there is no pain, there is no pus, but there is an infection. So it's not so easy, but we have to introduce our experience to this process and try to analyze it during every visit. And our weapons with infection: cleansing, rinsing, debridement, antimicrobial products. Start with cleansing. It's not like put the gauze with saline to the wound. It's more complicated. We have to cleanse. We have to do some mechanical process to cleanse, similar like cleanse my hands, our hands. We repeat this process when our hands are dirty, and the same in case of infected wound. So we rinse using the syringine and intravenous catheter. We use saline, but also another product with surfactant like Octanil, like Prontosan, and we use special wound pads, special sponges to improve our cleansing effect. And after a few visits, we observe that the wound bed is more redness. There is no sign of infection. It's very good weapon with infection. Debridement, of course, we have to remove all dead tissue, also infected tissue. Sometimes we are not sure, but we check. Oh, there is no bleeding. There is probably necrotic tissue, or we observe the bone, which is very soft, and we are sure that this is infected bone. So we have to remove it. It will be very difficult to fight with infection when the infected tissue is still in the wound bed. So the most popular in Poland are curettes. We also use scissors, scalpels, sponge, wound pads, maggots. Yeah, I like these methods. Maybe it's not so cheap, but very useful, and also with in wounds with infection. VersaJet, very good device for the debridement. Very precious debridement. It's very useful for the burn departments, and probably at this moment too expensive for the small white outpatient clinic, but maybe in the future it will be possible to use this device in also in outpatient clinic. Okay, and one case of the debridement or cleansing process, it's in the same time, the first visit, and it was around middle of the July, and it is the 12th September. So there is 2 months between these two pictures. Yes, there is completely covered by necrotic tissue. There was oedema. There was also critical line ischemia. And after successful revascularization, after removing this infected and necrotic tissue, after fighting with biofilm, we of course use antibiotics per dose, antibiotics also, but there was, it's only a part of our plan. There was very active cleansing, debridement, using of antimicrobial dressing. And there was Iodosorb, Acticoat. There was a lot of changing in the plan, but the Iodosorb was good because there was Pseudomonas, and we like to use this product in case of Pseudomonas. And next we start with Renasis, with negative pressure wound therapy, and one last Sunday there was Saturday there was apply a skin graft, and yesterday 2 days ago it was there was a first dressing changing after skin graft, and 90 or 80% is covered, is alive. Only this part was not in good condition. There was a Pseudomonas, so the Pseudomonas don't like doesn't like skin grafts, so it's risky, but we do it because there is no another possibility to close this kind of wounds. Cleansing, it doesn't mean the contamination. We use another product for cleansing. There are saline or products with surfactant, or sometimes hypochlorine when there is a very deep wounds. It's impossible to, it's forbidden to put this product to the very deep wounds, but it's good to use a hypochlorite. But in these two products, octanilin and protosan, has a surfactant, so it's better for cleansing. So it's not so easy to choose a proper liquid for cleansing and proper liquid for the contamination. But you have to use all these products and decide which one will be the best at this moment, in this case. We have one question. Can you repeat here the cleansing solution? Yes, we have a lot of product at the market, but only 2 products are sterile. So we try to use a sterile product for I clean this slide for cleansing. Saline, it's cheaper and maybe not so good with fight with infection, but it's cheap, and of course it's the first shot in our fight. But there are also 2 sterile products with surfactant, with antimicrobial dressing. In octanilin is octanidina, in prontacin it is a PHMB 0.1%. So it's good for antimicrobial, the first antimicrobial effect, and good for cleansing because there is a surfactant. Microdacin and granulacin, this is a hypochlorite. This is not so good in fight with infection, but it's very safe. It can be put to the small cannulas, to the small cases in diabetic foot syndrome because it's not toxic. So you know, it's sometimes very thin red line to decide which one will be the best. And Octanisep Brownol, this is rather decontamination liquid, antiseptic liquid, but there are also two completely another product. Octanisep is forbidden for deep wounds, and this is rather for the first visit when there is MDRO microbius. Brownol is good for Pseudomonas, is good for also for deep wounds, but it's not forbidden to connect with silver. So you know, a lot of products, a lot of solution. You have to choose, and the best. In my clinic, we have all of them, and we try to use one of each from time to time. We change it, but we analyze the situation on each visit. And antimicrobial dressing, our main weapon with infection. In Poland, it's good situation because our government covered this product, refund this product, partially refund. But it's very important for our patient, and it's easy to use this refunded product also in private clinics and in government also. And so we have maybe not so good refund procedures, but we have a good refund products, and it's a half of success. But I know a lot of countries when there is no good procedure and also not good reimbursement. So I try to be happy in this moment. Two products for Smith and Nephew: Acticot Flex and the Iodosorb. I try to talk you more about these two products. Iodosorb. Iodosorb is it's a very good product for the not so deep wounds, but for infected wounds, especially with gram-negative bacteria. I like to use this product in case of Proteus, Morganella, Pseudomonas. This is also the possibility to autolytic debridement, because after 2-3 days this plastoline is changing to the gel, and the gel destroy this biofilm, this soft yellow tissue in the wound bed, and it's easier to debride it with, for example, with curette. So it's good for fighting with infection, but not cannulas. It's not good for cannulas. It's good for venous leg ulcer, big area. We of course need some super absorbent, like a secondary dressing, but it's a primary dressing, and almost all cases of venous leg ulcers and not so deep diabetic foot syndrome. And this is our universal plan for the venous leg ulcer. Iodosorb 3-4 times every 3 days, and after this time it is not necessary. We use only the secondary dressing. When there is not so many exudate, you can use Allevin non-adhesive. When there is heavy exudate, use the Allevin Life non-bordered. And next, compression system. This is the multi-component compression system, very good for the second part of the healing, because there is a possibility to leave this product for 7 days. When there is not so many exudate, it's very useful and cost effectiveness to use this product. Sometimes we try to put it on to leave it for the 9 days when this wound is very small. and it is possible. So this is our plan for venous leg ulcer, and of course not all patients, but a big part of them. And ActicoFlex, it's nanocrystallic silver net covered with nanocrystallic silver, some depot of this silver, and during the 3 days this silver is put to the wound bed. This is flexible, stretch, and it's easy to prepare some small parts of this ActiCoat to put on to the small cannulas, and similar like on this picture, we cover all the wound bed, infected wound bed with ActiCoat Flex, and we have to protect this macerated skin with some cream or a Secura non-stink liquid, and next some super absorbent because it's infected wound, and of course there will be a heavy exudate. Okay, and this is what I said at the beginning. This is the deep tissue biopsy. It's maybe not so popular in all wound care clinic in Poland, but a lot of people use the Levine technique. It's also necessary, but it's not so precious like deep tissue biopsy. So we start with cleansing the wound without antimicrobial liquids. Next, we remove all the tissue, and next we take another curette, clean, sterile curette, of course, because all these procedures are realized in sterile technique. And we take the small part of the tissue using this curette from the deeper part of the deepest part of the wound, but this is not the necrotic tissue. It's the granulation tissue, for example, a part of bone. It's infected, but it's still alive. Yes. Sometimes we need analgesia, regional analgesia, for good deep tissue biopsy. And after 5 days, we have very good quality antibiogram. And we know that from this day, it will be better. The infection will be closed. Yes. Okay, and a few words about our team. It's at this moment probably the biggest wound care team in Poland. I don't know how we organize it, but it works. Now we have 6 doctors, 2 diabetologists, 3 general surgeons, and I am an angiologist, 24 nurses. It's very big and important part of our team. We still looking for the young, brave, and ready for education nurses, and good educate nurses is very, very important in realize this healing process. Sometimes it's a lot of months. We need 3, 4, 5 months to close the diabetic foot syndrome. So every visit is realized in clinic. So we need a lot of team, a very big team. Physiotherapists, it's important to activate to educate this patient how to use a wheelchair, how to use some offloading system, some special shoes, some ortheses. They spend a lot of time with lymphatic message, with compression therapy, with pressure ulcer prophylaxis. So we educate the families how to use some mathurats, how to positioning the patient. And dietitian also important, also in case of patient with infection, because They have no appetite. They have no enough. They don't drink enough, and there is important very fast intervention in this area. We work in 10 rooms. We have 6 treatment rooms and 2 podological rooms and 2 physiotherapy rooms. Last year we realized almost 20,000 visits, and almost all of them was around 1.5 hours. So it's a lot of work from 7 a.m. to 9:30 p.m. 2 shifts. A lot of work, a lot of patients, a lot of visits. Negative pressure wound therapy, it's very important device with our fight with infection, especially with case of phlegmon in diabetic foot syndrome, with preparing the wound bed for the skin graft, for some plastic surgery. So it's from my point of view impossible to close these wounds without this device. Now we use 23 negative pressure wound therapy devices, Renasys Go and Renasys Touch, and I remember exactly 13 years ago when I used first time negative pressure, and in the patient after general surgery, after colorectal surgery, and there was completely infected wound, and after a few days 50% of this wound was covered by granulation tissue, and I was impressed. It's impossible. I want to have this device. I want to use it. And now it's very popular. All these devices work in outpatient system. So patients come to our clinic every 3 days. And compression is necessary. Of course, in case of infected venous leg ulcer, we are we start very slowly with compression. But when we use an antimicrobial procedure, when we use an antimicrobial dressing, when we start with very gentle compression, and we increase this level from the visit to visit, it's safe. So of course, infection is contraindication for compression, but at the finish of infection, we start with compression. It's impossible to wait a lot of weeks with very heavy edema and observe it. And our multidisciplinary treatment team, yes, it's not full our team because now it's bigger, but altogether we try to create this multidisciplinary treatment team. And the whole message for you, the most important matters, cleansing. I work 8 years. I'm medical affairs director for 8 years in wound care center, and a few months ago I changed something in my mind. Of course, we cleansed the wound from a lot of years, but I observe how my colleagues from the other countries, how active is this process. It's not that passive. It's not that, oh, just put the antimicrobial liquid and wait a few minutes. No, you use the sponge, use the curette, you cleanse the wound after these procedures, and you observe, wow, after a few minutes, there's completely another wound. This is the first point with our fight with infection. And next, we use antimicrobial dressing, and there is a power for reaction of this product. When we just put this product to every infected wound, there will be no effect. you have to prepare the wound for this product. Debridement, use all these products, try to remove all necrotic and infected tissue. Proper culture technique. I promote deep tissue biopsy. I love these techniques. It's a subject of my educational grant. So I observe that it is more preciously than Levine technique. Appropriate antibiotic therapy, especially be careful when to start, to observe when to start intravenous antibiotic therapy. Of course, it's hard to organize in outpatient clinic, but it's not forbidden, and we have to do it, and we do it. But of course, it's expensive. Antibiotics, intravenous antibiotics are not so cheap. So we have to try. And modern antimicrobial dressing. We have a lot of antimicrobial dressing at the market. In Poland, it's almost all of them are reimbursed, so we are lucky. But of course, there is no another way. When we leave the wound after our activity for the 3 days to the next visit, there will be the same biofilm, the same pus, the same odor. So we have to stretch our activity, our antimicrobial activity for the 3 days. So it is the reason that we use antimicrobial product after this procedure conducted during the visits. And multidisciplinary treatment team. Of course, it's possible to be alone in a wound care room, but it is very hard. When you have a team, it's easier. It's easier to divide the experience, to help each other. For example, sometimes I had a patient from my colleagues, and I observe, wow, there is some new idea, and the same in opposite. My colleagues take my patient, and after visit, something was faster. So it's helpful. Then we have the possibility to exchange our experience during our daily practice. Okay, so this is the time for the questions. If you have any questions, not only about infection, but of course it's a main topic of our webinar, but if you have some another question, I'm ready to answer. We have 7 minutes, so don't afraid to ask me about everything. I don't see any questions. Maybe something interesting in maybe you're interested in another topics and other subjects. If yes, just write me, and it will be possible to organize next webinars about another problems, maybe you are interested in observe the cases, how we close these more complicated wounds. Okay, there is no question. I wait 10 seconds more, but okay. So it was a pleasure to spend this hour with you. I'm lucky because I like to talk about the wounds. So it's a pleasure for me to educate, to share with experience of my team. So thank you very much for your being with me, for your time, and welcome to the next webinars. Thank you, Dennis. I wait for this one sentence. Okay, so have a nice okay, have a nice evening, have a nice day, and I hope we will meet soon. Bye bye.